what happened to the rest of the fluid that is going on, that is passing through the kidney? It goes back to the circulation. It goes back to the circulations, and only about 1500 ml of water is being excreted by the body. That is the normal urine output. Less than 500 ml for 24 hours, that patient is oliguric, or the patient has oliguria. Urine output of less than 500 ml. And then the second part of your urine information is tubular reabsorption. As a recap, returns filtrate from the tubules to the blood of the peritubular capillaries. So the peritubular, these are the capillaries, these are the efferent arterioles that you see that is, surrounding the tubules. The kidney chooses the type and quantity of substance it absorbs. What is being reabsorbed? So water, sodium, glucose, urea, and creatinine. This is being reabsorbed in the proximal, in this area, the proximal convoluted tubules. So most of the reabsorption takes place in the proximal area, proximal convoluted. Sodium, 99% reabsorbed. Water, also reabsorbed. Glucose is 100% absorbed. Urea is reabsorbed. Creatinine is not reabsorbed. Creatinine will be excreted in the urine. I am sorry. Creatinine is not reabsorbed. Okay. So, if glucose is reabsorbed, why is it that in people who have diabetes mellitus, there is a presence of glucose in the urine? The amount of glucose, if it's too high, there is a limit on how much the kidney or how much these tubules can reabsorb. If it's more than the maximum capacity of your tubules to reabsorb the sodium and still more present in the blood, it will be excreted. So that is the reason why people who have hyperglycemia, the presence of glucose in the urine is because that sugar in the blood is too much. It cannot be reabsorbed by the kidney. So most of it can be reabsorbed, but if it's too high, the kidney cannot accommodate to absorb it. It will flow, it will go with the urine. Any questions on this? Tubular reabsorption. So sodium is being reabsorbed, water follow. Whenever there is sodium, water will always follow sodium, and also chloride. That's why sodium, chloride, they are always together. Whenever there is sodium, there is chloride, there is water. So if sodium is not reabsorbed, what do you think will happen? If sodium will not be reabsorbed by the tubules, what do you think will happen?
It's excreted.
It will be excreted, and if sodium is excreted, water will always follow it. So water will be excreted, so the person will have diuresis. Do you follow? Patient will have diuresis. What is diuresis? Anybody? Anyone? What is diuresis? It's if sodium is not reabsorbed, so it will be present on the tubules. So what will happen? It will be excreted. If it's going to be excreted, water will always follow sodium and also chloride. So the person will develop diuresis.
Low blood volume.
Ah,
It has low blood volume.
so when you say diuresis, frequent urination. So the person will keep on peeing because sodium and water is not reabsorbed. So water and sodium will be excreted. When it is excreted, water will always follow sodium. So water reabsorption is not happening. So water will be excreted and then person can keep on urinating. That is diuresis because sodium and water always go together. So that is what happening in people who have hypertension. In people who have hypertension, we are trying to block the reabsorption of sodium. So when sodium is not reabsorbed, persons will keep on urinating. That is the functions of your, so it will decrease blood pressure. So I think you have heard some people are taking diuretics or people are taking hypertensive medication. Those hypertensive medications, they are blocking the reabsorption of sodium because sodium cause high blood pressure. That's why we're telling patients who are hypertensive, low salt diet because salt can cause increase in blood pressure. And salt is sodium chloride. Do you follow?
I have a question.
Okay.
Certain people who are really into fitness, they take creatine supplements. So, from my understanding, it increases water retention in your body. Do you know anything about that?
Well, water retention, but you are perspiring, so water is also excreted.
But for people who take creatine supplements, it makes them sweat more. Is that what you're saying?
Yes. So water is also excreted. Do you follow? Because excretion is not only through the kidney, but it's also through the skin, through your lungs, exhalation. There are many ways on how water can be excreted from the body. Do you get it? Huh?
I have a question.
Okay.
So when a patient who have high blood pressure, so in order to treat that, we need to lower blood volume by increase the urine, by decrease the sodium reabsorption.
Can you repeat the question, B?
So when a patient who have high blood pressure, we need to lower the patient blood pressure by lower the blood volume.
Not the blood volume, but because when you say blood volume, that's the amount of blood present in the body. It's just the water that we have to excrete.
So we should increase the water excrete in the urine.
Yeah.
By decrease the sodium reabsorption.
Yes.
Yeah, and is there any relation between the blood pressure with the blood volume?
Blood pressure and blood volume, yeah, there is a relationship. When your blood pressure is high, that is the reason why we're giving diuretics to patients to lower the blood volume. So when we give, so that water and sodium cannot be excreted. It can be excreted when we are giving antihypertensive medication. That's why they could keep on urinating, they keep on peeing to decrease the sodium uptake, to decrease the sodium in the body. To decrease the sodium in the body,
Yeah,
decrease
thank
the
you.
sodium in the cell. Because the sodium is water retention, salt retaining hormone. And when there is salt, water also retained. Did I make it clear, V?
Yeah, thank you.
Okay. So sodium, if it needs to be reabsorbed, it needs it's a true active. When you say active, what do you mean by active mechanism? We took this up. When you say active,
Need
and what is
ATP.
passive? It needs an ATP because it comes from an area where there is less sodium to an area of more sodium. So more sodium on the extracellular compared to the intracellular. So in order for the sodium to be pumped out, it needs additional help through ATP. And then passive, it can go in and out. It can easily go in, it can easily go out. From an area of higher concentration to an area of lower concentration. This is what I was talking to you a while ago, aldosterone. This is a hormone that works on the distal tubules and upper collecting duct of the nephron unit. The aldosterone is called your salt retaining hormones. So salt retaining, it increases sodium and water reabsorption, increasing blood volume, increasing blood pressure. So in cases there is diarrhea or in cases there is hypovolemia, sodium and water is reabsorbed so that the blood pressure, blood volume can be increased. That is the effect of your aldosterone. And this is how aldosterone is being produced by the kidney. So sodium retention is stimulated when the blood volume is low or when the blood pressure is low. So that is one of the functions of your kidney. And this is what we are blocking when the person has hypertension. Because aldosterone is present in the body. So when there is hypovolemic or diarrhea or low blood pressure or low blood volume, the kidney will stimulate the release of renin. Renin will be when the brain know that the blood volume or blood pressure is low. It will stimulate the kidney to release renin. So activation of the renin, and this is located at the entrance of the kidney in what you call the juxtaglomerular cells. This is located on the opening of the kidney. So renin will be released when the blood volume is low. When renin is released, it will stimulate the angiotensinogen. Angiotensinogen is present in the liver and also in the blood, but angiotensinogen is inactive. They're not active. They're just circulating in the body. And when the time that the blood level is low, it will now become active. So when renin is released, it will stimulate the angiotensinogen. Angiotensinogen, through the actions of renin, will be converted into angiotensin 1. And angiotensin 1, through the actions of a converting enzyme, which is also present in the lungs, there is more of it in the lungs. It will stimulate the conversion of angiotensin 1 to angiotensin 2. And when it is converted into angiotensin 2, it will stimulate the adrenal cortex. This is the yellow structure on the top of the kidney. I don't know if I have.
I'm sorry to interrupt. I was wondering if we could take a little break, please.
Okay, come back at 11. Okay.
Okay, thank you.
You're welcome.
Thank you.